I got tired of all of the backgrounds on the other ones, so this is the background for this one. We're going to talk about GER. GER? Gastroesophageal reflux. Not necessarily gastroesophageal reflux disease or disorder, just gastroesophageal reflux. So here's the first thing you need to know about gastroesophageal reflux. It's normal. There is absolutely nothing pathologic that is occurring here. It is just a physiologic process that's completely normal because we've already learned in your anatomy and physiology that the lower esophageal sphincter is not functioning appropriately in a neonate. It takes a little while for that sphincter to really do its job and hold the contents of the stomach where it needs to be. So, and we also tend to feed babies lying flat on their backs. We hold them lying on their backs while they eat, either from a breast or a bottle. Then they tend to fall asleep while they're eating, and we don't want to wake them up, so we lay them down. And this just further contributes to gastroesophageal reflux. When there are complications that develop from the reflux of the GI contents back into the esophagus or into the mouth, then it becomes a pathologic process, and then we call it GERD. So during transient relaxation of the lower esophageal sphincter, gastroesophageal reflux will happen. It can happen during any time the pressure is increased intra-abdominally. So swallowing, crying, or valsalvas, like bearing down to poop, which, hello, lots of babies. So part of the reason why we see spit up happen is because we're changing diapers, jostling the baby around, squishing their bellies around, lifting their legs up and smushing their stomachs. So we will frequently see reflux happen in or around those time periods. Babies have delayed esophageal clearance, delayed gastric emptying. Nothing's really super working in the GI tract after they're born. It takes a while. So we want to watch for different signs and symptoms or cues, because normally once we see the cues that are associated with GERD or with gastroesophageal reflux, then we start to see some of the damage occur as well. So as I've already mentioned, we frequently see gastroesophageal reflux happen during the first year of life. It's super, super frequent in the first couple of months because they're still developing that lower esophageal sphincter. If we don't see the reflux resolve by a year to a year and a half, then we might start looking for something a little bit more organic in nature being the cause. A child born premature, potentially a premature infant that has been on a ventilatory support or has chronic, they call it bronchodysplasia in the lungs, those infants would be at a higher risk of developing reflux. We also have to look at the dietary habits of the caregiver if they are breastfeeding. So if they are taking in chocolates or coffee or really spicy or fatty foods, caffeine is a stimulant of gastroesophageal reflux for adults and infants and children. We also want to look at overeating and overfeeding. Frequently, the infant that is very fussy and having a lot of coughing or bradycardic events, and parents think that they're dealing with something that is actually like a cold or a flu, it's it's gastroesophageal reflux. And when the babies are fussy, the parents feed, and then the baby gets more fussy and the parents feed again. So it's just kind of this vicious cycle of overfeeding to try to calm a baby that needs to just kind of rest their gut. Um, Medications that a baby might be on, such as antibiotics. Whoops, I'm breaking things. Um, Antibiotics, medications that the caregiver that might be breastfeeding is on can also be a risk factor for developing gastroesophageal reflux. Smoking or alcohol use, food allergies, and then other GI disorders or congenital anomalies. We also need to look at the positions that are utilized during feeding and the patterns of the feedings. Babies that are like less than a month old and they're gulping down an entire 60 ml bottle at one time, and it only takes them 5 minutes to gulp it down, that is an inappropriate feeding pattern. They need to be stopped in between ounces and burped effectively. And they might need a slower flow nipple to stop them from gulping it. And then we look at the sleeping positions and patterns, because babies that are falling asleep frequently while they're eating and laid down immediately afterwards are more likely to have gastroesophageal reflux. And then we also look at other medical history, recurrent infections, and pneumonias. So these are some of the complications that can occur from untreated gastroesophageal reflux that goes on for a while, and we're dealing with the erosion due to the acids in the stomach. I'm sure you guys have all heard of Barrett's esophagitis. They could develop esophageal strictures and anemia from the chronic esophageal erosion. There can also be laryngitis, recurrent pneumonias, and asthma occurring simply from the inflammation from the erosion. We have also seen correlation with what we call ALTs, which are acute life-threatening events, and apneic events. They look very similar. An ALT is usually apneic spell coupled with severe bradycardia and some cyanosis, and that has been associated with GERD. So management of gastroesophageal reflux, the easiest and most most conservative medical management of gastroesophageal reflux in a neonate or an infant is to elevate the head of the bed and to keep the infant or child upright for 30 minutes after feeding. One of the ways, and parents will say it often, like, oh, well, our beds at home we can't elevate the head of the crib like you can in the hospital. So one of the things that we will advise them to do is to roll up or use like the pool noodles, or roll up a big sheet, blanket, or towel and put it under the head of the crib mattress, and then basically make like a little nest that the child can then their butts go in the little bottom of the nests to keep them from sliding down the bed. They can even use a super rolled up sheet and wrap it all the way under the child and the crib, so that they don't slide, but it doesn't need to be elevated that much. It just needs to not be flat. Smaller, more frequent feedings. So if their child is taking 2 bottles, so 120 mLs of formula or breast milk at a time every 4 hours, then they could cut that down to a 60 ml bottle every 2, with frequent burping in between. If the more conservative medical management doesn't work, such as the smaller, more frequent feedings or the elevating the head of the bed, then we can and will start the child on acid-reducing medications, so something like Pepcid or Tagamet, or I don't know, I'm trying to think of all the others, some of the H2 blockers. Less frequently, they will start a child on Reglan, and that's usually if it's assumed that the child has a condition that is causing a delay of gastric contents moving into the intestine. So the Reglan might be helpful just to move it along so that they don't regurgitate it. If none of those things work, then a Nissen fundoplication is usually the surgical procedure that's done for reflux. And basically they take the fundus of the stomach and they wrap it around the bottom of the esophagus. And these are done laparoscopically now, which is really quite nice, and they have a very minimal recovery period. Here is a glorious rendering of what a Nissen fundoplication looks like. So this is, see, there are so many cues when we talk about gastroesophageal reflux. So the first thing that we think about is recurrent vomiting or regurgitation. Usually it's just spitting up, but it's frequent enough to really be bothersome to the families. We might see weight loss or just not a great deal of weight gain, irritability. The things that really pique my interest are the respiratory symptoms and the hoarseness. So if I hear a baby crying frequently with a sound like their throat is sore, or the parents tell me that they are just always sick with this cough, with this cold, and they don't know why, and they maybe have periods where they cough and then they turn blue because of the coughing. To me, one of the first things I want to look at is not their respiratory system, it's their feeding. I've had a lot of patients who were worked up for a multitude of respiratory illnesses at less than 6 months old, and they did not have any of them. And the parents were frustrated and the doctors were frustrated. And I asked parents, like, how often do you feed? How often do they spit up? How often does this happen? And then when we started raising the head of the bed and keeping the baby upright for 30 to 45 minutes after feedings, just for kicks, it all goes away. So it's nice to see that happen. They will also frequently pull their little knees up to their bellies, and then after feeds, they might do this weird posture where they kind of arch their back and stretch their neck backwards. And they call it Sandifer syndrome. It's really not a syndrome. It's just they're trying not to hurt from the acid content that's going up into their throat. These babies might refuse to feed. They can develop chronic sinusitis and ear infections, and then when their teeth do grow in, they're going to grow in grody. Yay! So this is an important thing to be aware of. Not all children with gastroesophageal reflux vomit. And that's why it's really important to look for the irritability, the posturing, the coughing, and potential bradycardic events. Because, like I said, it's frequently misunderstood that a child will have a respiratory disorder when in all actuality it's not a respiratory disorder, it's not a cardiac disorder, it is literally reflux. They're just swallowing it. So we want to watch for these things. If we see the child bradying frequently, we need to let the physician know. But then also kind of be proactive about it and say, hey, let's start just these simple things and see if it helps. It might not be it, but let's see if it helps. Feed them more frequently with less large amounts. Make sure you burp in between, at least every ounce of formula or breast milk, and keep them upright. Let's try that. So another thing that we can do, because we've already talked about the smaller, more frequent feedings with frequent burping and the staying upright for 30 to 45 minutes after the feeding, whether they sleep or not. They can sleep being held in an upright position. So they need to be fed upright and they need to stay upright. We can also add thickening agents to the formula, such as rice or oatmeal. And that is fine to do under the age of 6 months. Other solids and other foods should not be utilized or added to any child, to any intake under age 6 months for a child.